Welcome, everybody, to our State of the Science lecture for the Society on Equity in Neuroscience. Really pleased to have the opportunity to have our guest with us today. SEQUINS, as the Society for Equity in Neuroscience, was developed and brought together to advance brain health equity and reduce disparities through science. And this lecture series in particular gives us a chance to really hear across a broad cross section of areas where there is some incredible work being done and disparities that we can be addressing as we come together more broadly as a community. Today we have with us Dr. Flatt from the University of Nevada in Las Vegas. He's an associate professor and the director of the Center for Health Disparities Research in the School of Public Health's Department of Social and Behavioral Health. His research works to better understand health concerns and needs of diverse LGBTQIA+, and that's lesbian, gay, bisexual, transgender, queer, intersex, asexual, and additional identities, individuals living with Alzheimer's and Parkinson's disease, and their caregivers and care providers. He has just a fantastic portfolio of research. I'm really excited to hear what he's going to feature for us today. Thank you so much. Dr. Flatt, the floor is yours.
Wonderful. Thanks so much for having me. Let me go ahead and share my slides and we'll get started. Can you see everything? Does it look good?
Yes,
All
thank
right.
you.
And you're not seeing the notes, right?
No.
Okay. Perfect. All right. Well, thanks for having me. And I'm looking forward to telling you a little bit around some of the work I've been doing for inclusive research, really thinking about LGBTQIA plus populations that are impacted by neurodegenerative diseases. So I wanted to just do some acknowledgments and disclosures. So I am especially grateful to my collaborators who I would not get to do this important work if it wasn't for them. So I just wanted to acknowledge them as well as my funding and let you know that I don't have any conflicts of interest to disclose. So the time today, I would like for us to really get on the same page first around terminology. I want to also emphasize why it's so important that we think about inclusion, but especially around thinking around, of LGBTQIA plus populations. Then I'll shift gears and share a little bit with you around what do we know currently in terms of neurodegenerative diseases and especially research. And you'll see that much of this focus is going to be on Alzheimer's disease and Parkinson's disease, given that's a lot of my work. You'll also see some aspects around things like cognition, memory, subjective cognitive decline that I'll also share. I want to leave you with a tool today. So if you're thinking about ways to ensure that your research is more inclusive, I'll share with you a tool that we use to collect information about sexual orientation, sex assigned at birth, gender identity, as well as intersex traits. I'll tell you what I'm working on right now with the hopes of where I hope we can contribute to the work and advance really the science around neurodegenerative diseases for LGBTQ plus populations. And then I'll leave some time for questions and answers. So let's get started with talking a little bit about terminology. And one of the things I love to always emphasize is what's most important when we're working with diverse communities is that we use the language that our communities use to self-describe their identities. And so that often takes an effort around cultural humility and openness to learning, but also just using the language that our communities use. So you may recall some terminology originated with the National Institutes of Health, where we describe sexual and gender minorities. And so sexual minorities, these represent individuals who do not self-identify as heterosexual. So this may include people who are asexual, bisexual, gay, lesbian, or queer, or they may use a different term. Gender minorities represent people who self-identify with their gender identity and or expression that doesn't align with social and cultural expectations around people's gender based on their sex assigned to them at birth. So this can include transgender, non-binary people, people who identify as queer or may use a different term. What's unique in sort of this umbrella term is it also includes intersex people. Intersex is not an identity. People are born with intersex traits or differences in their sex development. So those differences may represent people's reproductive anatomy, their chromosomes, or how their bodies respond to sex hormones. And so this is a group that represents around 2% of the population. We're often told as common as people with red hair. And so it's an important group that's often left out of the LGBTQIA plus umbrella. So really important that we think about that community. You'll also sometimes see the term cisgender, and this term is used to reflect people whose gender identity aligns with the sex assigned to them at birth. So this language is not language that we use with our communities. They do not usually know what sexual and gender minority means, or endorse this language. I've actually heard from communities often they're like, I'm not that. I don't know what that is. So this was a term that originated in 2016. It was when the directors of the Minority Health and Health Disparities Institute, NIMHD, as well as the director of the Agency for Healthcare Research and Quality, came together in 2016 and designated sexual and gender minority populations as a health disparity population for research. This no longer exists given shifts in federal priorities. And so this language has changed, and it's really an important time where we think around inclusion and how we ensure that especially gender minority communities, transgender people are represented in research. When we think about in terms of aging or looking often at neurodegenerative diseases, it's important that we realize that sexual orientation and gender identity evolve over the lifespan. So if you're conducting a longitudinal study, you may want to ask about sexual orientation and gender identity at more than one time point. So, as I had shared before, the language is quite diverse. I'm not going to go into much details of sort of these terms, but today I'm going to be using the term LGBTQIA+. Um, this really is an umbrella term. And as I had shared before, what's most important is that we use language that our communities use. And so, an example I often share, I have a really close friend. She's an 81-year-old transgender woman that was actually at the Stonewall Uprising in New York City. And she, at a time when she was coming to kind of accept her identity, the language used was transsexual. And so she still uses that language today, even though it's considered an outdated term in terms of when we work with broader community members. And so when I'm with her, I may use that language, but it's important to know, like, in a general sense, that language may not be appropriate when we think of broader communities. We would use the term transgender. So, just one example of how we use language. I really love this image from the Trans Student Educational Resource Group. This gender unicorn, what it represents to me is really how identities don't always fall neatly into these categories that we have on surveys, where we might be like, self-identify which of these identities represents you, right? And often where we're moving is that gender identity, gender expression, even sex assigned at birth, physical and emotional attraction, none of those fall in sort of a binary or categorical response. They're all on a continuum. So, the example for myself, right, as I've come to terms with my own identity, I identify as non binary, right? In many spaces, I still use he and they as my pronouns. And also in communities I'm part of, I'm married to my husband, and I may use the term gay when I'm describing kind of my sexual orientation. And some people might be like, well, you're non-binary, so that means you don't use sort of gender. So what would your sexual orientation is kind of falling into more of a binary? And I'm like, well, these are sort of how I self-identify. I agree that sometimes they may not fit all the definitions, but this is the language that I use currently. And so it's important just to note, like, this is how people evolve. This is like how we self-identify, and it's just important to use the language that we use and offer those options when we're collecting data. Another example, this word cloud reflects just a range of terms that communities may use to self-describe their gender identity. And I will tell you, I don't always know what all these terms mean. But what's really important, again, is that we use the language that our communities use. And another thing to consider is as you collect data on gender identity and sexual orientation, you often want to include a write-in option so people can self-describe their identity. And as you start to see communities endorsing specific identities more, you may want to have that as one of the options that they can select versus always self-describing. So I want to shift gears and talk to you a little bit around why inclusion matters and why we should be thinking about LGBTQIA plus populations when we're doing research, especially around aging and neurodegenerative diseases. So one of the pivotal moments in sort of LGBTQIA plus rights is really around the historical pieces that the community has faced in terms of a lack of equity. So the reason for the Stonewall Uprising, which is credited with being led by Marsha P. Johnson and Sylvia Rivera in the early hours of June 28th, 1969. And in this morning, it was not early hours. It was not uncommon for the police to raid LGBTQIA plus spaces. Often they would raid these spaces and arrest patrons if they had a certain number of clothing on that was considered not the appropriate clothing based on their sex assigned at birth. So it was actually illegal and they could be arrested. So, for example, transgender people, people dressing in drag, right? Anyone wearing clothing that was considered not their sex assigned at birth, that could be a reason for the police to arrest them. And often when they did this, they were very violent and brutal. And so the community in this early hours on June 28th really said, enough of this. And the story is told that the police were arresting either a transgender woman or a drag queen. And as that officer was arresting the drag queen and putting her into the back of his vehicle, he pushed her in. And as he pushed her, her heel went up and it hit the officer, and the officer started to attack her with his club. The patrons that had been pushed out to the street saw this, and this started 6 days of protests and violent clashes with law enforcement to say enough. We are tired of the police brutality. We are tired of the harms on our community. And what people don't realize is that often when people were arrested in these spaces, their picture would be posted in the local newspaper, and they would often be ostracized by family. They might lose their job, lose their housing, lose friends. And so this was a common area where really they were, ostracized by society because of who they were. And this was not the only place in the US that was happening. We were heard about this happening in places like San Francisco, Los Angeles, and Chicago, who were also fighting against the police brutality against the LGBTQ plus community, but especially the transgender community. So, in terms of just a short timeline, in terms of the LGBTQ plus history, I provide that here. I do want to emphasize that this is very lesbian and gay focused and doesn't highlight as much of sort of the experiences of transgender people. But we see the Stonewall riots happening in 1969. The reason we celebrate Pride in June is to honor that pivotal moment in LGBTQ plus rights. So the first Pride Parade happened in 1970. The rainbow flag was created in 1978. We see with the movement of these aspects, which left out here is sort of ignoring HIV, the epidemic that was happening in the early 80s. In 1993, the Don't Ask, Don't Tell policy was signed to forbid openly gay people from serving in the military. We don't see that repealed until 2011. right? And then we don't see same-sex marriage across all states happening until 2015. And so the community has faced a lot of historical pieces that have impacted things like exposure to health disparities. So, for instance, in the DSM, it wasn't until 1973 that they had started to remove language around being a homosexual was considered a mental health disorder. It wasn't until 2013 that language was being removed to say that, transgender people did not have a mental health disorder. Many LGBTQ plus people also grew up during a time where they faced persecution. For instance, during the McCarthy era, it was viewed that LGBTQ plus people were communists, and so they were systematically sought out in the government and fired. Very common to kind of what we're seeing today with some of the efforts in the federal government to eliminate focuses of research and people who are LGBTQ plus. Because of this, many LGBTQ plus people have aged without basic protections for human rights. So things like housing, employment, access to healthcare, as well as when we think about intersectionality. Imagine if you're an LGBTQ plus person, you're a person of color, maybe you're aging with HIV or living with a disability, how that can impact your experiences. So I often think about in terms of neurodegenerative diseases, especially in terms of aging related ones, that some of the cornerstones of successful aging are things like economic security. This is important when we think about marriage. Marriage is one way that wealth is shared between couples. So prior to marriage equality happening, if for example, me and my husband did not have any legal protections in place, and my husband were to pass away, and we hadn't secured our assets, his family would be able to come in and take those assets. For example, maybe my husband's name was on our home and my name was not. His family would be entitled to take my home from me. We also see these impacts when we think about things like social connections. So for many LGBTQ plus people, when they come out, they may lose biological family. And so many LGBTQ plus people have to rely on chosen family, which is a really important piece when we think about aging and access to who's going to support you with your care, as well as some of the historical pieces that may have shaped health and well-being, discrimination in healthcare, or being told that your identity is a mental health disorder may result in LGBTQIA plus people being reluctant to seek out care. We also see some of this, and this map is outdated, but we hear in terms of laws being passed to restrict access to gender affirming care for youth. Many of these laws are being applied to adults and older adults, and this also results in a reluctance to seek out care. So we estimate, and this is a crude estimate, that close to 3 million LGBTQIA plus adults are age 50 and older. We know that over a million of them are age 65 plus. About 1 in 5 identify as a person of color, and many of them are living in poverty. At least a third of them are living at or below the 200% federal poverty level. So, because of these unique aspects, we do see health disparities and challenges when we think about access to equitable care and resources for the LGBTQIA plus community. They're more likely to live alone. They're more likely to report experiencing discrimination when they access healthcare, and often they have less access to resources. So, I want to shift gears and talk to you a little bit about what's the current state of knowledge around neurodegenerative diseases and the LGBTQIA plus community. And so I want to start off with a study that I did back in 2021. This was published where we leveraged data from the behavioral risk factor surveillance system. And this data was really unique in that we looked across states. There were actually 25 states from 2015 through 2018 that had asked about sexual orientation and gender identity, as well as included from the Healthy Brain Initiative, a partnership between the Alzheimer's Association and the CDC, a subjective cognitive decline module. And in this, the question asks, in the past 12 months, have you experienced confusion or memory loss that has been happening more often or is getting worse? And so across this sample, we found that LGBTQIA plus people were much more likely to report this subjective cognitive decline, nearly 1 in 7, compared to about 1 in 10 for non-LGBTQIA plus people. We then explored across the subgroups who was experiencing the greatest concerns. And so here I highlight in red for you that the greatest concerns we saw were actually among lesbian, cisgender women, bisexual cisgender individuals, those who identified their sexual orientation as another identity, and transgender individuals. So you can see among these groups, close to 17% were reporting subjective cognitive decline. We did not find a higher rate for gay cisgender men, and this was a really interesting finding. And we think that part of this may be explained by the fact that there could be levels of privilege even within the LGBTQIA plus community that might be contributing to that. But unfortunately, we weren't able to necessarily test that with this data. In terms of those experiencing subjective cognitive decline in the LGBTQIA plus community, we found that they were more likely to report that their subjective cognitive decline resulted in them giving up day-to-day activities, needing more help with household tasks, and that it interfered with their ability to stay social, work, or volunteer. And so often we see a lot of these impairments are very common and what in some of the symptoms around mild cognitive impairment. Um, One thing to note is that subjective cognitive decline, it's useful for assessing sort of memory and thinking skills as a population level, but it is subjective and it may not actually represent objective challenges with memory. Um, it can be useful, but it could be due to things like depression, poor sleep, medication side effects, or something else that's contributing to sort of the memory and thinking challenges, as well as it could be inaccurate perceptions of aging, what might be normal in terms of memory loss that occurs with aging. So it's an area, though, that deserves further study. But subjective cognitive decline is considered a risk factor for future cognitive decline, as well as Alzheimer's disease and related dementias. Here in red, what I highlight is that what we found was no difference for LGBTQIA plus and non-LGBTQIA plus in terms of more than half of them did not talk to their healthcare provider about their memory loss and thinking challenges. We think this is due to also stigma associated with memory loss and potential Alzheimer's disease, as well as people may know that if you're diagnosed with Alzheimer's disease, it often can result in you losing your driver's license, which could really impact independence, as well as people's fears of having to go into long-term care settings. My colleague Ethan Cicero built upon the study that we did looking at subjective cognitive decline in LGBTQIA+, but looked specifically at transgender people, uh, people of color, from racial ethnic backgrounds, so specifically American Indian, Alaska Native, Asian, Black, Hispanic, Latino, multi-race, and those who identified their race as another identity. And so before I showed you that we were close to 17% for LGBTQIA plus, but we found that among transgender people of color, right, it was 22%, with it being lower among white transgender people, as well as cisgender people. So really highlighting some unique aspects for transgender people of color. As part of my career award from the National Institute on Aging, I leveraged a study that looked at medical record data in Northern California. It comes from Kaiser Permanente and the research program for genes, environments, and health. And so I was able to look at electronic medical record data from 1996 through 2015, as well as we had information on sexual orientation as part of this research program for genes, environments, and health, where they asked about lesbian, gay, and bisexual identity Humanities in 2007, and then got permission to link the participants' data to their medical record. So this program had over 2,000 people in it, as well as 4,300 lesbian, gay, and bisexual people. And we looked at health diagnoses using ICD-9 codes in the medical record. So in 2007, we saw that the cumulative prevalence was about 7.4 for LGBT people compared to about 9% for heterosexual people. So it was lower. But what was surprising is when we looked at the age at which people were diagnosed with dementia, we found that the LGB individuals were being diagnosed about 1 year earlier. As well as we looked at longitudinally in terms of incidence and found that there was no difference for gay men and bisexual men compared to heterosexual men. But among lesbian and bisexual women, we found a higher odds of dementia compared to heterosexual women. And they were actually being diagnosed about 2 years younger compared to heterosexual women. So again, a potential signal that is a concern for us in terms of dementia risk among the LGBT community, as well as that similar pattern we saw with subjective cognitive decline, where gay men did not have a higher risk. There's also been some work leveraging medical record data from CMS, so specifically using Medicare beneficiary data. And back in 2015, they looked at Medicare beneficiaries and looked at ICD codes in terms of dementia and found that for transgender people, about 18% had a diagnosis of dementia compared to 12% for cisgender people. What's unique in this data set is that for transgender people, they were able to identify them based on ICD codes in terms of using gender affirming care. And it's important to note that not all transgender people access gender affirming care or may not use sort of their Medicare beneficiary aspects to receive that care. So likely some groups were underrepresented. This study was repeated back in 2023, where they leveraged data now from the Medicare beneficiaries from 2008 to 2017. And you can see here, actually, the prevalence of dementia was even higher. So among transgender women, around 1 in 5, transgender men, over 21%, where it was around 12 to 14% for cisgender men and women. So again, a potential signal where we're seeing higher concerns around dementia for transgender community members. Another study led by Dr. Shea and Dr. Liu leveraged two population-based samples to look at risk of, well, really more to look at odds of cognitive impairment in LGB people using the National Social Life Health and Aging Project, and then among same-sex couples in the Health and Retirement Study. And in both these studies, they found that there was an 80% higher odds of cognitive impairment after they adjusted for demographic aspects, as well as some lifestyle factors among LGB people. So a higher odds of cognitive impairment compared to heterosexual individuals. So again, a signal around potential concerns. I have another colleague where we started thinking about aspects around how can we ensure that community members get the care that they need if they're experiencing memory problems. And so I had shared before with you around concerns of discrimination in healthcare settings. And so we found that among transgender and non-binary older adults who were experiencing subjective cognitive decline, they were also more likely to report that they experienced discrimination in medical settings. And so this study really highlights that discrimination in healthcare could represent a barrier in terms of early screening as well as diagnosis when people are actually having dementia in the transgender community. Similarly, we looked at this among using the Fox Insight study among LGBTQIA plus people living with Parkinson's, as well as women living with Parkinson's and men. And what we found is that among cisgender heterosexual women, they were more likely to report discrimination, as well as LGBTQIA plus people living with Parkinson's disease. And so, similar to our last study where we highlighted discrimination could be a barrier to receiving care, we think that this also likely could be playing out for people that are living with neurodegenerative diseases, that they may be receiving less care or may not want to access care as frequently because they perceive experiencing discrimination. Another study I wanted to share with you that I think is really important is around how do we think about engaging our community members, LGBTQI plus people in research. And so we conducted another study leveraging the Fox Insight data and highlighted how sexual orientation and gender identity differences likely shape attitudes and awareness and experiences in terms of participation in research. And so here we highlight some of the areas. So transportation came up as a common barrier for LGBTQIA plus people, as well as for women in terms of participation in research. We also found there were aspects around sort of the information, as well as feeling that researchers may not understand or respect people's cultural beliefs. So we found that was also an area that stands out. So there's some unique opportunities when we think about making neurodegenerative disease research more inclusive, that we need to address also barriers and how research is structured in terms of the forms, thinking about transportation barriers and other equity issues. So I mentioned I want to leave you with some tools today to really think about how can you encourage and include LGBTQIA plus people in your own research. And so there's been quite a bit of reports. Some of these I know some of them are being pulled down from websites given shifts in federal priorities in the US. But I want to share with you some tools to consider for the collection of sexual orientation, sex assigned at birth, and gender identity. So first, I want to emphasize that the National Academies of Sciences, Engineering, and Medicine put out a report in 2022 around best practices for the measurement of sexual orientation and gender identity. And we've used a lot of this to guide our work. Around 2024, we worked with the National Alzheimer's Coordinating Center. They were updating the UDS version 4.0 and including some social determinant modules in there. And we were able to get questions about sexual orientation, sex assigned at birth, gender identity, and intersex traits added to this. So here I give you some links of just resources, as well as we've had a couple of papers published that highlight some best practices of how to collect sexual orientation and gender identity information. So this tool, I wanted to just share more with you. Something that we got a lot of questions about, and it's important that we think about training of the individuals that may be asking the questions. So we gave a little prompt. Sometimes these may be self-administered, other times you may have an interviewer doing them. But we wanted to give a little bit of details of why we were asking these questions. And so that initial question really states that we're going to ask about SOGI information, and the purpose of asking about it is so we can improve health, well-being, and quality of care. Right, this is really to emphasize that we know that LGBTQIA plus populations experience health disparities, and so it's important that we can tailor care and resources for the community. We also define what we mean by gender identity, and how gender identity can be different from a person's sex assigned at birth or their sexual orientation, and that it can also change over time. So, the first question we start with is asking about gender identity. As I shared, we allow people to check all identities that apply. So it is quite common that a transgender person might also endorse, for instance, identifying as a woman, as well as a transgender woman. All right. And so it's important that we allow that. The other piece that we include, and it doesn't show here, but we allow sort of branching options. For instance, I don't talk a lot about two spirit, but two spirit is a spiritual term that's used by American Indian as well as other indigenous communities. And so you should only use that language when you're working with indigenous communities. We would build in, if it's self-administered, maybe try to build in some skip patterns if it's online, or the interviewer would follow those patterns. We also allow a write-in option. And so we've really moved to away from having language that others people. So we try to say, like, I use a different term and allow them to write that in. Then we ask about sex assigned at birth. Then we ask if people have ever been diagnosed by a medical doctor or other healthcare professional of having an intersex condition. It's also called difference of sex development. And define that and allow them to select the options and then select similar to what we do with gender identity. Sexual orientation is also a check all that apply. You will see in here that this also includes two-spirit identity for indigenous communities, and it's important to note that indigenous communities may describe their two-spirit identity as representing their gender or their sexual orientation, or it might be both. Um, so again, these are just some best practices that we've been using to educate the community around ways to ensure research is more inclusive. I'm going to shift gears and just tell you a little bit about some of my current research that we have going on. The first study that we have is called the RISE Registry, or Research Inclusion Supports Equity. This is a partnership between the University of Nevada, Las Vegas, Emory University, and the University of Tennessee, Knoxville. And what this registry has been focused on is ensuring that the LGBTQIA plus community, those living with memory loss, had a diagnosis of dementia, or are a caregiver of an LGBTQIA plus person living with memory loss or dementia, um, could have access to research. Right now, the registry website has been taken down. This was one of the research grants that was terminated by the federal government. So right now, our registry link is down because we had some concerns around the protection of the data for our LGBTQIA plus community members. We did get the grant back, and we're currently on a no-cost extension. So we're continuing a lot of this work, and we'll be disseminating some of the best practices. Another project that I have is called the Stonewall Generation Study. This is supported by the Alzheimer's Association. This really builds off that research that I shared with you of what we learned about subjective cognitive decline. And so, what we're doing in this study is actually using a telephone survey and collecting information about objective cognition using the telephone interview for cognitive status. We're looking at differences for LGBTQIA plus and non-LGBTQIA plus and comparing sort of differences in their cognitive health, as well as looking at risk and protective factors that might be associated with cognitive impairment. The next study I have, and I've shared a little bit around Parkinson's disease. We just wrapped this up at the end of July. So we did one of the first studies funded by the Michael J. Fox Foundation for Parkinson's research. We've already published on our AIM-3 that looks at the experiences of caregivers, but we're also looking at the unique needs of LGBTQIA plus people living with Parkinson's disease and their caregivers, looking at differences by sexual orientation and gender identity, as well as we've looked at the attitudes of healthcare providers in terms of meeting the needs of LGBTQIA plus people living with Parkinson's and their caregivers. So more of this will be coming out soon. We're actually working on AIM-1 at the current point to publish it. Another really cool study that I wanted to share with you is with some colleagues, uh, Dr. Rosser and Dr. Shippey at the University of Minnesota. They're leading an R01 study that's testing a culturally responsive intervention to improve care at long-term care facilities for LGBTQIA plus populations. We've published quite a bit on some of our initial work. And so we're actually wrapping up the intervention, and these results will be coming out soon, really to think about how can we intervene on ensuring access to care. Another project I've been working on is with a colleague, Jarman Ye, at the University of California, San Francisco. We were part of a group called Open House, one of the groups in San Francisco that focuses on providing affordable housing to the LGBTQIA plus community that's aged 50 plus. As well as we worked with them to co-design the first adult day program for LGBTQIA plus older adults, specifically people living with dementia as well as other forms of disabilities. This has been a really amazing project. It's really centered around what the community wants. It's called the Open House Unlock Community Day Center, but the participants call it Club 75. It's just really incredible. And so we're in the process of doing work around the evaluation of it. The next project I wanted to share with you is I'm working with my colleague, Dr. Joel Anderson. We're adapting the Savvy Caregiver intervention for LGBTQIA plus people living with dementia right now. We're kind of in our, just in our first year, just completed that. And so we're looking at ways to ensure that this intervention will be really welcoming and inclusive to LGBTQIA plus caregivers of people living with dementia. Next, I have an R01 study called Rainbows of Caring. This study is looking at ways that we can ensure that we can best measure caregivers of LGBTQIA plus people living with dementia and focus really on their unique needs. So some of the things we'll be developing new measures around are like things like how do we know who a caregiver is? How do we assess or adapt existing questions to make sure that chosen family members can be represented, as well as understanding unique health contributors and challenges that caregivers may be facing? I also have a new study that just started this past August. It's called Rainbows of Aging Research Readiness, or ROAR. Up, it looks like aim one. Oh, okay. It has something in it. But aim one, what we're going to be doing with this study is really co-designing with the community ways to ensure that LGBTQIA plus people can have access to Alzheimer's and related dementias. Clinical trials. So we have a community advisory board that's guiding all the work. We're going to be interviewing community members, assessing really intersectional correlates that may be contributing, to their lack of willingness to participate in clinical trials in dementia. And then we're going to be developing an educational module. We're partnering actually with the company, it's called Vibrant, that actually developed the All of Us study to develop this educational training program that's co-designed with LGBTQ plus community members. This work specifically is focused on those that are underrepresented in the community, so transgender people, people of color, and those from low socioeconomic backgrounds. I want to close today with really a call to action and asking you all to really think about ways that we can advocate for inclusive research. I highlight here a lot of what I faced over this past year was having many of my grants terminated, as well as a lot of uncertainty around sort of how do we support junior people? Can we continue to do this research given shifts in federal priorities? And so I really want to encourage you to think about ways that you could stand up for inclusive neurodegenerative research. Some of that you need to assess your own sort of experiences where you are. I know that I come from a place of privilege. I'm a tenured associate professor, right? I also, right, have a lot of privilege in my own identity and experiences. So never am I saying you should take a risk with your career or your livelihood in terms of how that would shape, but I want you to think about ways that you could contribute. Whether that's writing an op-ed, talking to policymakers, talking with communities, even simple things like volunteering to support the community in leadership. Maybe that's supporting the transgender community or making sure that you have a booth at your local Pride celebration. Any of that that could help to support research. Another piece that I think is so important is that we support early career scholars and our international students. They are experiencing some really unique struggles in terms of doing research that's truly inclusive, that represents diverse communities. And so, ways that we can support early career scientists are going to be huge. Anything that we can do, stepping up. And so I just show this image because both it shows mentors, but shows my commitment to junior people to ensure that they can continue to do this work in a time where we know that the resources are even harder to acquire. Many of the junior faculty and PhD students that I'm supporting have applied to multiple grants, and they're just more competitive than they've ever been before. And so, stepping up to support and mentor, and also offer any financial resources that you can to support early career scientists is so important right now. So, I'm going to end there, and I am ready for any questions that you have.
Thank you so much, Dr. Flatt. That was just an incredible journey you've shared with us, truly. And I really appreciate you starting us off with just setting a foundation so that listeners use language and remember to ask the people they're working with. I really appreciated those comments just from the outset and then reminding us all the way through. Um, I will be monitoring the chat and want to, of course, open it up to our other panelists to ask questions. Please, Bruce.
So, Jace, thank you for such a wonderful talk. Very enlightening for me. So I'm grateful, and I'm sure it'll be for many of our SEQUINS members. The question I
Pleasure.
have, and please excuse me for my own ignorance, but my understanding is that there's a significant survival disparity with LGBTQI plus individuals generally experiencing higher mortality rates and lower life expectancy compared to their heterosexual counterparts.
Mhm.
Presumably, this survival bias impacts cognitive decline and dementia studies by potentially distorting findings, whether it's the onset, whether it's rates, whether it's risk factors in aged LGBTQI plus populations. If this is all true, Jace, how should we
Mhm.
approach it?
Mhm. You're so right. And like, so it is, right? We think of this in some language we use, right? We think of it called like accelerated aging in LGBTQIA plus populations. We also think of it as a weathering effect that we've seen, right? Just another term to kind of describe it. And we see some patterns that are similar in terms of what we see with other communities of color. So specifically like Black and Latino groups that we see have higher rates of risk for neurodegenerative diseases, specifically a lot of the work on Alzheimer's disease. Um, so I think for our studies, given this, you might notice some of my inclusion criteria. So we allow a lot of studies on neurodegenerative diseases, not so much Parkinson's disease, but Alzheimer's disease. The age cutoff is usually age 65. Um, for our studies, we actually have a lower age for inclusion. It's actually age 50. And that is given some of our thoughts are really unique. So studying this group of LGBTQIA plus people, they're not a monolith, right? So the experiences I've shared, like gay men seem to fare better than lesbian women. But when we look within, we also often find the highest rates of disparities among bisexual individuals and also especially among transgender individuals. And there is a huge issue around survival bias. I've often hear even from the community, for a transgender person to make it to age 50, right, is a huge survival piece. Um, so we're thinking about it. It's really hard. It's especially hard right now, and where the resources are. So inclusion age is one way that we're addressing it, using community-based participatory research approaches to build trust and reach the community to ensure better representation, is another piece. We really focus on racial ethnic diversity within the LGBTQIA plus community. So we're not just capturing those that may have the greatest resources, which are always overly represented in research. So that's one of the things we're focused on. Um, and in terms of like your question, I've been thinking there's another scholar that's been doing some work way more advanced, and like I do more social behavioral with a little dip into the biological. But they've been studying, and I think it's really fascinating. It's called the cardiovascular conundrum. And I don't know if you've heard about that, but it's this idea that like an exposure to chronic stress impacts the physiological parts of your body. So they've done this work specifically among the Black community, and also they did it among a sample of LGB people. And what they find is that basically this chronic exposure to stress results in it changes heart rate reactivity, right? And so it's this idea that like communities that are exposed to stress over their life course, this is potentially this cardiovascular conundrum could be a marker of this weathering effect that we're talking about, and you could capture it in a physiological way. Right, there are other pieces that it doesn't, right? Socioeconomic resources. What's really unique for the LGBTQIA plus community, and this could be an issue with our recruitment, is that, but we tend to find higher rates of education in the community. I don't think we can always say it generalizes. It may be an issue with our recruitment or our sampling, but in my study that I shared looking at risk in Northern California, we found a higher risk in lesbian and bisexual women, but they had higher rates of education, which should suggest a protective effect, but it's not playing out that way. And so it's really complex, and and we're not quite sure how to answer it, right? We don't have a lot on educational quality. I think you need to know more about it. Where did they receive their education? Could also shape like geographic aspects. But it still suggests to us there's something going on when we think about a potential disparity for the community. One hypothesis that I've had that could be another marker of chronic exposure to stress, and it's pretty crude, but we see higher rates of PTSD in LGBTQIA plus people. So could that be, it's the most severe form of stress exposure, but it's more than double what we see in heterosexual cisgender individuals in our population-based samples. So it's where I've been thinking, but I'm not. It raises really good questions, and this is why we need more scholars to go into this work. I feel like I'm just like on the tip of like describing it. Here is what we're seeing, but we need people that could get into, deeper into the area to help us better understand what could be contributing to this. And I think it could be useful for all people, right? As we learn, like if it is a stress aspect, right? And that we can show this is a reason why we need more focus on equity. If it's related to lack of social resources, then that's another example of these are modifiable factors that we could address that could reduce people's risk. So. Yeah.
You have just identified a whole portfolio of work that needs to be done, and an agenda moving forward. And I hope that can be summarized from this discussion today, into a paper.
Yeah.
Your point on capacity is a critical one, and one I'd love to hear your perspective on. There's there's the identifying the problems, and there's a lot of work still to be done in that space as you've just described. There's also people who are doing work either in health services research, intervention development, in clinical or public health programs, may not have yet begun to even think about some of the questions you've asked, but we're at also a workforce and capacity, and like the people who have expertise in doing this. What would you recommend, kind of the broad area of people doing research, to researchers in general, and how we can be building our teams and be thinking about the questions we should be incorporating, from identifying problems to being able to incorporate how to best address them as part of our larger questions in intervention research.
Hmm. Well, I think it's like the starting point would be really looking at the research, the data collection and making sure it's truly inclusive. That's the first start of it. Like, if we don't have the information, there's no way that we could ever answer these questions. So that's why I like start with like asking about sexual orientation and gender identity. Right? There are some best practices, but honestly, like having anything is better than not having it at all. So that's a great way to start. I think then it's, supporting, like we need to share this information with other scholars, with other researchers. I think a commitment to training junior people, and creating these supportive environments where all of us are at like, we're always, I think it's just the nature of this career, we're always going to be at like kind of capacity, like, or beyond it, and so it's going to take this commitment to mentoring and bringing in people with unique skill sets, or really the time and interest to pursue the work. I think about it like you talked about, like health services research and all these different areas. And so I don't always know if I'm like, my broader vision, I'm trying to kind of, and I'm going to use this word, like attack it from all these different perspectives. So I try to think about it in terms of risk. Who's at risk? Who's caring for the person at risk, and how are they navigating that? And then what are the systems that they have to navigate, to determine their risk and to get their care? So I look at it, in that way, kind of, I think about it as like this ecosystem, right? Or we could think about it as like an ecological model, even, of like looking at all of the different influences, and like we may not be able to answer all of those at once, but like answering a piece of it might help us to solve another part of the puzzle later on. And so just being like thoughtful around how all of the different disciplines and the different sort of levels of analysis can help us to address this broader issue around kind of neurodegenerative diseases for populations that are, considered health disparity groups. So I hope that helps.
Yes, thank you. We're very invested in building capacity, and definitely not just engaging more people in doing this research, but to your point, engaging people earlier in their careers, with the skills they need to ask these questions. We are at the
Awesome.
top of the hour. This was fantastic.
Perfect.
Bruce, would you like to close us out? Thank you so much for joining us today. This was really incredible. We look forward to sharing it with a wider audience.